Okay, good evening everyone and welcome to tonight's webinar. We have with us tonight panellists Dr. Gary Kilov from Principal at Seaport Practice and Nicole Frayne, Pharmacist and Credentialled Diabetes Educator from WA. Our speaker tonight is Professor Merlin Thomas, who's a Head Biochemistry of Diabetic Complications and NHMRC Senior Research Fellow at Baker IDI Heart and Diabetes Institute in Victoria. Tonight, Merlin will be presenting on non-insulin anti-diabetic agents, and tonight we're discussing SGLT-2 inhibitors, conceptualising a new approach to diabetes management. The session will be recorded and that will be available after the session tonight and tomorrow. If you have any questions throughout the evening, please type them in your chat box and we'll be reading those out at the end. We have a few case studies to go through and we can discuss those as we go through the night. So I'll hand over to Merlin and we can get started. I can find your presentation. Sorry, Merlin, I'll just bring it back up again. Get there. Okay.
There we go.
Go for it.
Well, good evening, ladies and gentlemen. Thank you for coming out and listening on your computers to this really interesting story about SGLT-2 inhibitors. They really have revolutionized the management of diabetes in the last year and a half since they became available in Australia. And they are rapidly becoming a second-line agent of choice for the management of type 2 diabetes. But it is important, particularly as diabetes educators, that you're familiar with the challenging parts of not only how they work, but also how to best use them in clinical practice. Because perhaps unlike DPP-4 inhibitors, they do have a side effect profile and they do have issues that need to be addressed as part of an education platform in type 2 diabetes. We're going to go through a couple of cases tonight to illustrate some of those challenges. But just to begin with, we'll start off talking about how SGLT-2 inhibitors work and potentially how they can be best used in your patients. Next slide, please. So just as a basic understanding to begin with, what normally happens in a healthy individual who has sugar levels around about 5.5 millimoles per litre is that a significant amount of glucose is filtered into the primary urine every day. About 180 grams of glucose is filtered. 99.99% of it is reabsorbed in the proximal tubule of the kidney, so that what ends up in the urine of that original 180 grams is only less than 100 milligrams. And this is the reason why urine is reported to not taste very sweet, because there's next to no glucose in normal urine. Next slide, please. In diabetes, of course, when you have high sugar levels, much more glucose is filtered into the primary urine, and the tubular reabsorption pathways simply cannot cope with this excess. They try very hard, but ultimately sugar spills over into the urine, giving glycosuria and the symptoms associated with that: polyuria, weight loss, and also an increased risk of infections. Next slide. So in diabetes, you are reabsorbing more glucose than you otherwise would. In fact, as the threshold for glucose spillover increases, most people with diabetes will retain an extra 60 grams of glucose every day. So if you imagine someone with diabetes who's already got high sugar levels, their body, and in particular their kidneys, are pouring another 60 grams back. And this is one of the reasons why sugars can be difficult to control. Next slide. The rationale for SGLT-2 inhibitors is that by inhibiting the major reabsorption pathway in the proximal tubule by about 30%, an additional amount of glucose can spill over into the urine. On average, that's about 60 grams extra a day, or an additional 300 kilocalories. Next slide, please. To simply understand this and explain this to your patients, you can think of glucose control much like you think of a glass of beer. In a healthy situation, on the left-hand side of your panel, you'll see that you never have a rise or never have a fall, and you've got plenty of capacity, so that even if you had dessert tonight or ate something sweet, you would never exceed the capacity of the glass to keep the glucose in it, and you get no spillover, which is why you don't collect glycosuria in healthy individuals. In diabetes, the capacity increases to try and retain more glucose in the system, and that is because of the high glucose being filtered. But eventually that capacity is not sufficient, and a small amount of glucose spills over into the urine. Drugs like dapagliflozin and the other SGLT-2 inhibitors, all they do is make the capacity smaller in the kidneys. You've got a smaller glass, which means if you overfill it, you get more spilling over. And that's simply how they work. Lower capacity means if sugar levels should rise after a meal, you get a large amount spilling over into the urine. Next slide, please. And so that seen in this slide, you can easily see that individuals with diabetes on a drug like dapagliflozin, an SGLT-2 inhibitor, for the same glucose level on the bottom axis, they actually have much more of that filtered glucose spilling over into the urine. So, for example, at a level of 10 millimoles per litre, when roughly 300 or 320 grams of glucose are filtered into the urine, under normal circumstances in blue, no glucose ends up in the urine. Whereas with this agent, 40% of that filtered load, or next to 100 grams, is now lost into the urine. Next slide, please. And this results in a significant improvement in glucose control, excluding the one trial illustrated here with the word CKD, which was done in patients who had kidney failure. In other words, in whom the drug wasn't going to work anyway. If you exclude that one, overall, you can see that you get a very nice reduction in A1C by using this agent. Next slide, please. But the real advantage of this agent is not just that it lowers glucose, that by losing that glucose into the urine, you also lose 300 kilocalories from your body every day. Next slide, please. And that 300 kilocalories is not insignificant, and it causes a negative calorie balance in some individuals, enough for them to lose weight. And you can see in this 4-year study, those people on an SGLT-2 inhibitor losing 3 to 4 kilos and keeping it off for a period of time. I've had reports to me from general practice in Australia of patients losing twice this much because they have a much higher starting glucose level. You pee out more glucose, you lose more weight. And that really is its key advantage. Next slide, please. But the really exciting thing is the weight loss that is there is not just drying out, but in fact, the weight loss is largely a loss of fat. And in these studies looking at MRI, looking at the amount of fat in individuals, you give this agent, you pee out glucose, and in fact, you lose significant amounts of fat because your body goes, crikey, all that glucose is going from my body. I better not burn up glucose. I better burn something else to keep my sugar levels up. And in this case, in patients with type 2 diabetes, you burn more fat, and that means you get thinner, and your visceral fat, your bad fat, goes away. Next slide, please. So what we're going to do now is cover a couple of cases to show what happens when you start this agent and look at some of the clinical scenarios. You've heard now why you might want to start it, for glucose control, for the added benefit of weight control. But the real challenges come once you start it. Next slide, please. So here is Graham. He's a standard 50-year-old man. He works as a taxi driver. His blood pressure is not too high, and he probably has an average weight for a 50-year-old man in Australia, a BMI of 30. He's a non-smoker, but he doesn't do much exercise with his taxi. Okay, and the question is, he's been diagnosed with diabetes about 18 months ago. He's got high lipids and had high blood pressure, and is on a range of medication. He's on metformin as monotherapy, a cholesterol-lowering agent, suvastatin, and a blood pressure-lowering combination. But his A1C is simply not under control at 7.9. So the question then comes from a practitioner's point of view. He needs more therapy. He needs to be under control. Next slide, please. And in trying to decide what should be the best next therapy, there are a number of considerations. Certainly it's important to lower the hemoglobin A1C, but that's not the only issue. There's issues of sustainability, hypoglycemia, tolerability, weight control, compliance, cardiovascular risk, and cost. Next slide, please. So to begin with, and I'll open this up to the panelists to give you some of their experiences, let's think of Graham. And the reason that we want to use one particular agent is not that it works, because all agents work, but we hope this agent is going to be tolerable to Graham, be able to be used by him, and keep being used by him. Because if he doesn't tolerate it, sure as anything, he won't be taking it. So to the panel, what do you think about Graham? How well do you think he'd tolerate an SGLT-2 inhibitor?
So we'll bring Gary and Nicole back on and see if they want to make any comments about Graham.
Hi. I'll take the lead on this because I have a patient who's very similar to Graham. He happens to be a taxi driver as well. And so the issues around selection of a second-line agent, as Merlin said, really involve a whole range of parameters. Particularly if you've got somebody who's driving a public vehicle, you want something that's not going to cause hypoglycemia, which is going to reduce your selection, narrow your selection. But I think the main focus of this particular question is around tolerability. And my patient actually had problems with the issue around increased urinary frequency, polyuria, which, as he pointed out, for a taxi driver, this is not a good thing to have because you sometimes just can't stop and go to the toilet. So it would be relevant, I think, to have the discussion around issues about urinary symptoms. So somebody like this gentleman, Graham, may start getting some symptoms of benign prostatic hypertrophy. You'd want to ask about that. You'd want to ask about issues around any other symptoms that may suggest that he's at high risk of some of the adverse effects, balanitis and such, if he's had a past history of that. In terms of other issues around these agents, they generally tend to be quite well tolerated. But I think in his specific circumstances as a taxi driver, it may be a bit of a challenge.
Any other considerations, Nicole?
Although I agree with all that Gary said, I guess for me it would be the hypo. And I think for a taxi driver that lifestyle modification is always difficult. So any weight loss that you could engage with that might promote some other changes or encourage changes would be useful and not limiting for him. So as a taxi driver. But I agree with how he tolerates the urinary frequency.
Thank you. Okay, can I switch to the next slide, please? So just as a background, the panelists have been commenting on the increase in urine output that occurs with these agents. And it's absolutely clear that if you put glucose into the urine, you cause an osmotic diuresis. And that is proportional to the amount of glucose that you put into the urine. So, for example, if you have very high glucose levels, let's say an A1C above 10%, and you give this agent, within an hour of giving it, you're passing more urine. And that sometimes is a really positive experience because you know the drug is working. Sometimes it's a negative experience because you're trying to drive the car. And therefore, it's really quite important to try and maximize the positives and eliminate the negatives where possible when using this agent. On average, a patient, once their sugar levels come down with this agent, will be only peeing around about 300 to 400 mils extra every day, or the equivalent of 1 bladder volume. So even though this guy is a taxi driver, what you'll find is that he only has to pee once more often a day. And that shouldn't be a problem for his tolerability. If he had terrible sugar levels, like they were very high, usually for the first 5 to 7 days, he will have more urine than that. But once his sugar levels come down, as they will with this agent, you'll find his diuresis settles, and it becomes very well tolerated. And in fact, in clinical trials, only about less than 5% of individuals ever complained of polyuria or nocturia or other symptoms. Next slide, please. There are, however, need to be precautions. And of course, you'd encourage someone to take their SGLT-2 inhibitor in the morning so they don't have to eat at night when they're asleep. You might also say that this agent is not appropriate for people, as Gary mentioned, who have got bladder, pelvic floor, or prostate problems, which is very, very likely in patients with diabetes. BPH is much higher in males with diabetes, and of course, larger women who've had larger babies with their diabetes often have pelvic floor issues that also are exacerbated by these agents. And also, when you look at older patients with reduced mobility, you don't want to have them peeing once, twice more often a day. Having said that, most people who are younger, have got good bladders, and in particular are early in their course of the diabetes, tolerate the urinary symptoms extremely well. And in fact, some of them respond very positively to them because they know every day that this drug is working. Because when they don't take it, their urinary stream will fall off. Next slide. A lot of people are worried that by losing fluid from the body, you would also get dry. And certainly that's an issue for taxi drivers getting constipated. There's some data, and certainly with canagliflozin, that there's a slight increased risk of constipation, but not with the other agents. Most of the time because you are drinking more anyway. Next slide. But there's one really important issue in men, and in particular in uncircumcised men. When they're overweight, diabetic, uncircumcised, they often don't have very good genital hygiene. And unless they're prepared to look after their hygiene, you can see from the red bars here, this agent significantly increases the risk of developing a genital infection. And this is balanitis. And if there is redness and swelling, sometimes this can need a circumcision, which is kind of a drastic step when using an agent. So you want to be careful in using this agent. When you're educating, you tell them it's very important to look after hygiene, and if it goes red, you get it treated, because that's very likely to happen. And in this trial, it's about 5% overall. Next slide, please. So here's the other issue that was mentioned by the panelists. What about driving on this agent? We've already said it might help his weight and his A1C, but we're really worried about his driving risk. So, Gary, to begin with, what about hypoglycemia with this agent?
Yeah, so the great thing about this agent, and we're now spoiled for choice actually with agents that do not in themselves cause significant hypoglycemia, added to background therapy of metformin, the risk of hypoglycemia is exceedingly low for this gentleman. It is important to remember though that SGLT-2s added to agents that do cause hypoglycemia just simply by lowering blood sugar will bring an individual into the zone of higher risk. Say if it's added to insulin or sulfonylureas, hypoglycemia does become an issue. But I think in this particular instance that would not be a concern for me at all.
And that's why I think those RACGP guidelines of stop and review are so valid in looking at what other therapy was on. In this case, metformin not an issue, but maybe this is the time to start introducing some blood glucose monitoring so we can see the benefit of the drug therapy and obviously not for looking for hypos in this case, but as something that he can be looking at patients for seeing the benefit of the therapy.
Thank you. I think clearly in a taxi driver of this kind of situation that your treatment priority, sure you want to lower the glucose, but the thought of hypoglycemia is entirely abhorrent to this sort of situation. You have to do whatever it takes to avoid hypo, and one of the ways to do that is by using an agent that works through an insulin-independent pathway, so will not cause hypoglycemia. Next slide. So when you look at, for example, in a head-to-head trial of patients on metformin in which dapagliflozin, an SGLT-2 inhibitor, was added, compared to a sulfonylurea, like glipizide, you can see the glipizide in the first year of therapy, 40% of them experience hypoglycemia, compared to less than 4% with dapagliflozin. And that fundamentally means it's a far better choice for a taxi driver, the top priority being to avoid hypoglycemia. Next slide. And the reason that it does not cause hypoglycemia is shown here. So here are healthy subjects whose sugar levels range from 5 now then up to 22 if they're increased. And you only see glucose ending up in the urine when you're above 11. Next slide. Keep going. And so that, keep going, please. One more. So here is the yellow bar. Sorry, go back one, please. Here's the yellow bar in patients on dapagliflozin. You can see that you get more glucose at every glucose in the urine for every glucose level. But by the time you get to 5.5 millimoles per liter, there's next to no glucose ending up in the urine. Again, like the glass story that I showed you before, if your glass isn't filled up, it doesn't spill over. And this is why these agents don't cause hypoglycemia on their own or in combination with metformin, because there's next to no glucose being lost if there's next to no glucose in the system. So you simply cannot drop any further. Next slide, please. So the other question is, he is 50 years old. He should have quite a long life ahead of him. So the other thing that we need to consider is a therapy that not only works today, but that will keep working in the hopefully 20 years this guy has got ahead of him in terms of controlling his glucose, controlling his cardiovascular risk, and improving his health. Again, the panelists would like to comment on sustainability.
Nicole, would you like to go first?
I guess this is probably more a question I wanted to answer. I would be looking at how long he had his diabetes for, and I guess we're not looking at pancreas change there with an independent pathway of getting rid of glucose, but how long have we got that evidence for? And I'm hoping Merlin can address that for us in the next couple of slides. Over to you, Gary.
So certainly the great thing about this agent, as Merlin, as you pointed out, was its insulin-independent mode of action. And we know that unfortunately diabetes is progressive with a sustained decline in beta cell function. And we know that at diagnosis about 50% or even more of that beta cell function is lost and inexorably progresses. So agents such as sulfonylureas that rely on viable beta cells are going to have their usefulness determined by the remaining viability of beta cells. With SGLT-2 inhibitors, their action is dependent on, again, as Merlin said, the glucose that's being filtered. So as long as renal function remains robust and glucose continues to get filtered, these agents will remain sustainable. So we know, and again, thanks to Merlin having done a great study, the Nephron study, which was done in Australia in GP land, so very, very relevant to the patients that I see and that I'm sure many of our delegates see. We know that about 50% will have chronic kidney disease, but probably around a fifth will have an EGFR that starts dropping into levels where filtration starts becoming a problem. Now, as you're aware, there are different thresholds for these agents in terms of how low an EGFR you can prescribe them. But this is about efficacy, not about safety. So these agents will remain sustainable for as long as renal function remains robust. With dapagliflozin, it's an EGFR of greater than 60. With empagliflozin and canagliflozin, it's an EGFR of greater than 45. But these quirks are not about safety. They're simply about regulatory, what was applied for and what these agents were approved for. So I think this gentleman, whose renal function is pretty good at the moment, he's fairly on in his trajectory of diabetes. His blood pressure is reasonably well controlled. I don't think he's a smoker. I think many of his other cardiorenal risk factors are well controlled. So hopefully we can protect his kidneys for a long time and therefore have this agent be useful for a very long time.
Thank you, Gary. Could we go to the next slide, please? One of the real challenges in a young person, a 50-year-old with diabetes, is getting a program that not only works now, but keeps working. As Gary mentioned before, some of the agents have got a notorious what's called Nike effect, that they work beautifully to begin with and then very rapidly lose their effect. And this is sometimes called beta cell exhaustion. You could say it's also patient exhaustion because they're exhausted with the hypos and the weight gain and stop taking the drug. But either way, with the sulfonylurea, you see that by the time you've got to 2 or 3 years, you've lost much of the efficacy that you had to begin with. And that, of course, is a real disaster in a patient who has, struggled to get control for the first few years of their diabetes, and now their drugs stop working. So it's one failure after another. Next slide, please. The real advantage of agents like dapagliflozin and other SGLT-2 inhibitors is that by working on the kidney rather than working on the pancreas or any other organ, just specifically on the kidney, that does not wear out. And so as a result, the effects are very sustainable. In the blue line shown here, the effect that was seen at roughly around about 3 to 4 months was very comparable to what you saw a little bit later on. There's a mild drift up, and that's probably the metformin failing rather than the dapagliflozin failing. Whereas clearly with the sulfonylurea, particularly over those first 2 years before rescue, you can see that classic Nike effect. Next slide, please. And as Gary mentioned, the rationale for using this agent is the same rationale as you would say, do more exercise or improve your diet. But because not working on the pancreas, essentially, allowing the kidneys to do the job, means that the pancreas can sit back. Say, well, I have to make less insulin because that glucose has gone away through another mechanism. Instead of being taken up to the muscle, it's been taken up into the urine. But your pancreas doesn't know that you've done exercise or that you've just peed out the glucose. From the same point of view, it might be a good way to keep those few beta cells that you've got left in someone with type 2 diabetes, going for that little bit longer. And the suggestion would be that this might lead to better beta cell survival. But that really needs to be proven in very, very long-term studies which are currently underway. Next slide, please. So the other really important thing is that he's diabetic, he's got high blood pressure, he's got lipids that were high on a statin. The other most important thing is, why are you lowering his glucose? Why are you managing him? The major reason is because you want to reduce his risk of having a heart attack. So the question is, will an SGLT-2 inhibitor dovetail into that plan to improve his cardiovascular risk?
Gary or Nicole, do you want to comment?
Yeah, the impact of SGLT2 inhibitors is rather interesting, and it's not all that straightforward. So as you're aware, we see a glycosuria. So there is some increased dumping of glucose, but as the name SGLT2 suggests, which stands for sodium glucose linked transporter, when you're getting rid of glucose, you're also getting rid of some sodium. So there is a bit of a natriuresis. And with the volume loss and some sodium loss, you have a resultant decrease in blood pressure. So that's certainly an advantage in a population where blood pressure is often difficult to treat, and that would be a positive cardiovascular a move in terms of reducing cardiovascular risk. We also have weight loss, around about the 3 kilograms. Weight loss, reducing central obesity, as Merlin pointed out, is a positive effect in terms of cardiovascular risk. The effect on the lipid profile is interesting because there is a small increase in LDL. So we don't want LDL, those are the lipogenic particles, to the atherogenic particles. We don't want those to increase, but they go up by about 5–7%. But there is a concomitant rise in HDL, which is the protective cholesterol, and a reduction in triglycerides. So you get this kind of mixed picture, which overall may well be neutral. So we do have a number of surrogate markers that would suggest possibly a benefit. It might be neutral, but of course these surrogate markers really need to be borne out, or at least the effect needs to be borne out in cardiovascular safety trials, which are of course underway for these agents. So I think overall, on the data that's already available, these agents appear to be at the very least safe and possibly providing some benefit.
Nicole, did you want to add anything to that?
Well, no, Gary covered that all perfectly. I just wanted to play that, not devil's advocate, but Merlin, so if the trials that are in place, when will we see some results around its benefit in cardiovascular?
Well, that's a fantastic question. Let's go to those next slides, please. So, as Gary mentioned already, that there is a significant effect of SGLT2 inhibition on blood pressure. It's not indicated for blood pressure lowering, but if you take someone with a blood pressure around about, let's say, 130 millimeters of mercury systolic, and you add in Forxiga, you lower the blood pressure about 4 to 5 millimeters systolic, which is about what you would get with a thiazide diuretic. So overall, its effects are very similar to what you would see with a diuretic. Next slide. And the advantage of it is that that reduction that you can see with the blue line there, compared to the sulfonylurea in red, is sustained over a period of 4 years. So it works nicely to lower the blood pressure and keep the blood pressure low. Next slide, please. As Gary mentioned, there's also these paradoxical effects on lipids. So in fact, the LDL goes up by about 3%, and the triglycerides, sorry, the HDL also on the right-hand side also go up about the similar amount. This is about the same effect that you get when you salt restrict an individual, because that also affects lipids. Next slide. So the real question is, what's the sum total of effect? We know that there's weight improvement, there's blood pressure improvement, there's lower insulin levels. Those should be good. But there's slight increase in lipids, and that might be bad. In fact, when you look at the trials done to date so far and add them all up, you'll see the number of events are relatively small. For example, in the MI column, there's only 63 events. But overall, with this agent, there were a lower number of myocardial infarctions. And in particular, the rates of heart failure were lowered by 2/3. But you can't really tell from these studies because there's just too few events. You'd like to say, wow, this is really exciting, but it's not enough to be sure that they have any benefit. Certainly we can say on the basis of this data that they're safe, but will they have benefit? Next slide. And this is what was being referred to before. There are now major studies going on to try and see whether lowering the glucose, lowering the blood pressure, lowering the weight adds up to mean a lower risk of cardiovascular disease. The largest of these trials is DECLARE-TIMI, which is a trial of patients with cardiac disease randomized to receive dapagliflozin or placebo. And that's probably going to come through, I would think, probably about 3 to 4 years' time. There are other trials with, for example, empagliflozin, which is yet to be launched in this country, which will probably come through earlier, maybe as soon as the end of this year, to give us an idea of whether this strategy is the right thing to do. So it's a really exciting time to say, we've got something that works very nicely. We're going to find out very soon whether all of those changes in surrogates really mean improvements in hard endpoints. Next slide, please. So here's another challenging situation. The average age of diabetes in Australia is 66. So half of those 2 million Australians with type 2 diabetes are over the age of 66. How will you use an SGLT-2 inhibitor in these kinds of people? Next slide, please. So here's Pam. She is 71. She's got systolic hypertension. Her BMI is pretty average for a 71-year-old Australia at 27. She's a non-smoker and she doesn't do much exercise. She had diabetes for about 18 months. She also had gestational diabetes. She has bladder problems and dizzy spells occasionally, but her sugar is not well controlled with an A1C of 8.2, an EGFR of 65, and on metformin 2 grams once a day, together with the same sort of lipid lowering and blood pressure lowering therapy that you'd expect her to be on. Next slide, please. So again, you have the same sort of balance. Weight and sustainability are not so much of an issue. You don't have a long time to worry about here, and weight is not a priority for her. But she has other issues to be concerned about: compliance, hypoglycemia, and tolerability. And again, I'll open it up to the panel. What do you think an SGLT-2 would do for her? How well do you think a 71-year-old with these issues will tolerate an SGLT-2 inhibitor?
I think putting myself in the perspective of Pam, that anything that could potentially worsen those dizzy spells or my bladder problems and affect my quality of life are just going to be something that I don't want to tolerate. So whether that is really an issue for Pam is something that we should discuss. Okay?
Yeah, I think one of the other issues around tolerability is we do have, I guess, greater risk of falls, and so we'd want to be careful about hydration. She does have an uncontrolled systolic hypertension, but we'd want to make sure that we don't put her at risk of postural drop. She's not on a diuretic, so the risk of volume depletion is not that high. In the first case, we spoke about bladder issues, and I think, Merlin, you ran through a few examples of situations where you might avoid an SGLT2 inhibitor. So you'd want to know about her pelvic history, pelvic health, her bladder history. The fact of avoiding hypos, of course, is a very important feature in this individual. An elderly person suffering a hypo can be a fatal event for all sorts of reasons. They can fall and fracture a hip, which can also be an issue around hypovolemia. So we'd want to make sure that those issues are, she's not at risk of dehydration. The compliance issue, the one thing about these agents is that they are once daily, usually can be taken with or without food. So from that perspective, it's about as easy as it gets. But it would certainly put her off, I think, if she were to develop significant urinary symptoms or postural symptoms.
Gary,
Thank you, Gary.
Thiazide diuretic. So, Merlin, does that depletion matter whether it's a thiazide or a leak? Is that
Yeah, you're right, Nicole, that she was on a thiazide diuretic mix with her ARB for controlling her blood pressure. Now, we do know that in combination with an SGLT-2 inhibitor, you can get an augmented diuresis with this combination, but it's not a contraindication. However, it is something to be worthwhile noting. And in particular, I would note that this individual has an eGFR of 65. So she has got a pretty low kidney function, not impaired yet, but it's heading that way. And of course, if she's on a diuretic and then you add this in on top of that, the likelihood is that she'll have an acute drop in her kidney function. And so in many of these situations, if I were to use an SGLT-2 inhibitor, I would often come off the thiazide diuretic and use this as a way ahead because of that concern. But of course, there are many other reasons in this particular individual that you wouldn't be using an SGLT-2 inhibitor. Next slide, please. So the issue really is volume depletion. When you look at the trials, you can see that overall, in terms of patients complaining of postural dizziness with this agent, it wasn't that common. And largely this is because patients who have postural dizziness are never in the trials and never involved. There is a real and significant reduction in intravascular volume. And so really precautions should be taken in anyone who's prone to be getting dry. And in particular patients in diuretics or patients who are living out in the community and getting hotter on occasions, you should be very vigilant in this sort of situation. Next slide, please. But the other issue is urinary tract infections. In a woman, of course, women are 10 times more likely than men to get UTIs and will affect probably 3 in every 5 women in their lifetime. Of course, diabetes probably doubles that risk altogether of diabetes, and this is primarily mediated by glucose in the urine. So you would expect an agent that increases glucose into the urine, like an SGLT-2 inhibitor, to potentially increase the risk of UTIs. Next slide. But it's interesting when you look at the trials, again, the red bars represent those using an active agent, an SGLT-2 inhibitor. There wasn't really an increase in UTIs. And this seems strange and counterintuitive until you understand what this agent does. It makes you pass more urine, and if you pass more urine, you empty your bladder more often. And in particularly younger men and women, when you pee more often, you actually get less bladder stasis and your UTI risk goes down rather than up. And so that offsets a lot of that risk. Still, if you had someone with an increased risk of UTIs, particularly urinary retention, you'd use this agent only with caution. Next slide, please. And just to show you the other real issue, and that is genital infection, as opposed to urinary tract infections. Now, these are genital mycotic infections, or candidiasis. And this is clearly increased, whether you talk about with DAPA, CANA, or empagliflozin, it's increased roughly 3 to 5-fold. So on average, between 1 in 13 and 1 in 10 women who are treated with this agent within the first 3 to 4 months will develop genital candidiasis. Next slide. And this can be quite confronting. Most of the events occur quite soon, and the symptoms really are quite sudden onset of severe itch, discharge, pain, and dysuria associated with this agent. And on examination, it's usually obvious that you've got thrush. Most women don't need a doctor to diagnose this. Almost all diabetic women will have had genital thrush at some point already during their diabetes. They'll be very familiar with it. But to have this agent and know that it causes this can sometimes be quite confronting. Next slide, please. The advantage of it is that if you take someone and put them on it, and you're prepared to educate them and say, look, when this drug works really well, glucose will be removed from your body, which is a great thing. That glucose can sometimes make the thrush that exists already in your genital area to grow more voraciously and overgrow and cause an infection. If that happens and if you get a sudden onset of symptoms, you go and get it treated immediately. You don't sit on it until next week and see if it's any better. You get it treated immediately. Many doctors suggest, don't come and see me or wait until tomorrow to see me. Just go to the pharmacy and treat it because it's very treatable and you only need 1 to 3 days of treatment. And that not only eliminates the infection but also eliminates the carriage so there's no recurrent infection. And if it doesn't settle, it wasn't thrush to begin with. And that's the easy way to do it. And very few patients have recurrent events. So having genital thrush with this agent is not a reason that it should be stopped. However, it is a confronting thing, and unless you've got a practitioner and indeed an educator that's prepared to say and explain what a genital infection is to every woman that's on this agent, really you've got no right in using it because it's such a common thing and it's such a very significant thing that it's worthwhile going through the symptoms and also having an action plan because 1 in 10 individuals is worthwhile knowing what to do if that happens. And in an older woman in particular, where actually genital thrush is slightly increased anyway, it's really important to be able to say what's going on and what to do about it. Next slide. There is some evidence that genital hygiene improves, that reduces the risk of developing thrush. For example, wiping after urination, some other practices like probiotics also make a difference. But essentially the best thing is that when glucose comes under control with these agents, you get less glycosuria, and so your risk of developing genital infections really disappears after the first 6 months. And so that's the really advantage of this agent. Next slide, please. Next slide, please. Here we go. Click.
Ah, it's not going. Sorry.
It's not going.
Sorry.
Try one.
Here we go.
Okay.
Actually, Merlin, before we go on to case 3, we might answer some of the audience questions. I'm just conscious of the time.
Sure.
So if, in case we don't get to some of them, we might try and answer some now.
Okay. And or the panel.
Yes. So we have one question. My concern is whether this class of drug will cause injury to the kidneys.
Well, that's a very good question because, of course, they work in the kidneys. Well, what we know from the trials that have been done so far is that there's no evidence that they are harmful to the kidney. Indeed, you can be born without SGLT-2, and this is a condition called benign familial glycosuria, and your kidneys are perfectly healthy and last you a perfectly normal life. So even 100% inhibition, remember this drug is only about 30% inhibition, even 100% inhibition doesn't seem to be damaging to the kidneys. The really exciting thing is, well, maybe it's protective as well, because if glucose doesn't get into the kidneys and stays in the urine, maybe the kidneys are protected from the load of glucose going into them. And a number of trials are going on now to try and see whether these agents might actually protect the kidney, but they're certainly not harmful.
We have another question. What expected drop in HbA1c would you predict?
Gary, do you want to answer that one? Okay. I'll answer it if you like. The reduction in A1C depends on where you start. The amount of glucose in the urine depends on how much you spill into the glass to begin with. So again, just like my beer glass scenario, if you have a very, very high glucose level, you poured a lot of glucose into your glass, you have a big spillage. So the A1C reductions that you can see if you start off, let's say about 12%, can be somewhere in the range of 3 to 4%. Whereas if you start off with an A1C about 7.5, there's relatively little glucose elevation, and therefore there's less glycosuria. So the reduction in A1C can be more modest, and sometimes be only about 0.5 under that circumstance. So the bigger the glucose, the more the effect. The lower the glucose, the less the effect.
Maybe a question for Gary or Nicole. Have you found that clients who are taking this medication and know that it is draining more glucose from their blood glucose are more likely to eat inappropriately?
I haven't found that from the patients we've been using in our general practice. I've found that they're actually loving the weight loss, therefore are more motivated to continue with the changes they already have been educated on. So I haven't found it in the group that I've been using it. In fact, the weight loss has been very positive, and that's what they're feeding back to me. I haven't even had a lot of them complaining about urinary frequency, and that's probably because it's only a very short-term effect for them.
Anything from you, Gary?
I think Gary's disappeared.
Oh, I have. I can still hear him though. Maybe?
One of the interesting things that I've heard is that when patients have switched from a sulfonylurea to an SGLT-2 inhibitor, they've felt that they can miss meals. So, for example, a businessman who had to take his rigid meal to avoid hypoglycemia, he can have his business lunch, and if he takes dessert, he'll just pee most of it out. Whereas if he misses a meal and doesn't have an elevation in sugar, then he won't pee any glucose, and therefore he won't be low. And so it allows people to lead a flexible existence, so that if you do eat more, then it's just like overfilling your glass, you're going to spill more over. And so it does give you a little bit more flexibility in your eating. I've not heard eating more as a result, but certainly this guy was now happy to have his business lunches. At the same time, he's also happy to miss meals, because hypos were no longer a risk with this agent compared to sulfonylureas.
Also, do you need to ask clients to increase fluid intake to offset osmotic effect?
Nope, I wouldn't do that. I mean, you drink according to thirst, and if you're thirsty, you drink. I think that there's no requirement to drink beyond thirst, and I don't think that that's any benefit at all. What you'll find is that most patients will just naturally drink a little bit more. The really important thing from an educator's point of view, of course, would be to say what you drink should not contain calories, and that if the goal is weight loss, don't go and drink something that's sweetened juice or whatever. Here's an opportunity to get more water into your life, or more low-calorie alternatives. And if you are going to feel thirsty, you have to eliminate any excessive calories, and again, then you'll get the real benefit of the calorific loss in the urine from these agents.
Anything to add to that, Gary or Nicole? No.
I want Merlin to go further than that. For someone that's on a fluid restriction, this is going to could possibly impact on them.
Yes, we don't have many people who are on fluid restriction unless they're probably, they have volume issues, and anyone with volume issues probably is not going to be on this agent. They'll be on a DP4 or something like that, rather than anything with volume up or down. You're not going to play with this agent. It's really for the early diabetes. You want blood pressure, you want weight loss at the same time as you get glucose control. You want that positive effect early on to make you feel positive about diabetes. And you want a drug that you feel that's working. And it's kind of like insulin. The first time you give insulin, you know that it works because suddenly you feel better if you're symptomatic. Whereas if you're an asymptomatic patient, you come in and say, I've never had a symptom of diabetes. You say, I've got diabetes, doctor, and it's high. And you're on this medication. You go, how do I know that it's working? I don't feel any different. But the real advantage of this agent, if it has one, is that you truly feel different when you use it. And of course, if you're a 70-year-old if you're a younger individual, to know that your drug is working, and particularly for a man to actually see that your drug is working when you're standing in the urinal, is actually quite a positive thing, because then that's that, you know, biofeedback reinforcement, which is so critical for managing diabetes.
Okay,
Perhaps
one
I
last.
can just come back to that last slide.
Sure.
I just want to mention very briefly just that last case, because I think it's relevant and very timely. Because as of 1st of April, we're going to see patients not only using it as a single agent with metformin, but also in combination with insulin. Next slide, please. So Kevin, here's a guy. He's now on. He's clearly overweight. BMI is 37. He's on 100 units of insulin a day, but his A1C is 8.2. In this sort of situation before, the general practitioner would often, you know, just ramp up the insulin over and over and over again to try and get control. And of course it doesn't work, and you end up being on hundreds of units of insulin. Next slide, please. But now you have an alternative in this situation where you haven't got control and you've got very high weight, and your insulin is not working because you're hugely insulin resistant because of your high sugar levels and your weight. So the advantage is using an agent that doesn't rely on insulin, in fact, like an SGLT-2 inhibitor. So for Kevin, an SGLT-2 inhibitor now becomes a viable alternative to that disastrous cycle of increasing insulin, and not getting anywhere. At the same time, it has advantages for controlling his weight, his cardiovascular risk. And I wonder if Gary wants to comment on the use of an SGLT-2 in combination with insulin and where it's going to be in new practice as of 1st of April when it comes in on a PBS subsidy.
Thank you. And firstly, apologies. I'm not sure what happened. My computer had a bit of a conniption and lost audio earlier. I think it's a wonderful addition because, as you pointed out in one of the earlier slides, it works very effectively the higher the glucose is. So it's great to have it as an agent that will help postprandial excursions and augment a basal insulin. So I would certainly have a low threshold for adding it to a basal insulin. And because of its glucose dumping effect, it does mean that the individual requires less insulin, so it has an insulin sparing effect. And also because of the weight loss, it will also mitigate some of the potential weight gain that occurs with insulin. So it really is a very nice combination. So it's something that I can see as being a very useful combination. The other problem we've had in the past, which is gradually improving, gradually settling, is the frustration that we've had in adding a second-line agent and then, because of PBS restrictions, having to discontinue it because it's not approved in combination with insulin. So, for example, going the old traditional way, you could go metformin, SU, and add insulin, but you couldn't do that with a DPP-4 inhibitor, for example. You couldn't do it with an SGLT-2 inhibitor until now. So now adding an SGLT-2 as second-line agent is something we can do with more confidence, because we know that when we do progress to insulin, it is approved with insulin. So it does have the benefits in terms of the benefits for the patient, but it also has benefits in terms of negotiating the PBS.
Just on that PBS negotiation though, because I haven't seen it being used, obviously I'm in general practice, so it's PBS limited. Is it going to be metformin, a basal, and then an SGLT-2? What are the restrictions on the oral therapy with the basal before you put in an SGLT-2?
So I think interestingly now it's going to be an add-on to basal, but I think what will happen is that the natural progression will be to have your SGLT-2 as your second-line agent and then add your basal on top of that.
But I'm thinking more in practice now. Say, for example, if you had someone metformin plus a DPP-4 with the basal, and you thought that that still might be a beneficial use of an SGLT2 to control and use a different pathway, is that not going to be PBS?
I'm not aware that you can use a DPP-4 and SGLT-2 together in any context. I think it's an either or, and I think what you're going to find is that when patients aren't controlled on a standard therapy, you're going to use this as a way forward because it's a separate mechanism. And therefore, if you're on a background of metformin and insulin, instead of that vicious cycle of increasing insulin, here you can get on with not only control, but also weight loss and other things as well. And that's really positive. But there's one thing to remember, Gary mentioned earlier, although this doesn't cause hypoglycemia, you must remember if a drug works and you're on insulin, the insulin suddenly becomes more likely to cause hypoglycemia. So in an individual like this who was variable in his compliance, who suddenly takes this agent and his glucose comes in control, he goes, wow, I'm getting under control. I'll start using the drug like I'm supposed to. He takes his 100 units of insulin. He may be more at risk of hypoglycemia. And during that first phase of using an SGLT-2, it's really quite important for him to be not only educated and vigilant about hypoglycemia, but be prepared to down-titrate his dose of insulin if he's getting those symptoms. And many of patients end up doing exactly that, reducing the amount of insulin that they require. And that is really a positive thing. But avoiding hypos in this context is also very critical. Okay, we could go back to questions because the additional slides don't provide any further information.
Okay. Just bring up. There wasn't too many more questions, and I'm conscious of the time. So we'll see what we can. Do you see SGLT2 inhibitors being used as a diet drug in the future for patients seeking weight loss without diabetes?
No. This agent is indicated for glucose lowering. It is not a weight loss alternative, nor is it a weight loss agent. Sure, it does cause weight loss, but the rationale behind it is glucose lowering. It happens to cause weight loss. Of course, it radically synergizes with exercise and dieting and all those other things. So if you're going to do those things, it'll help, but it's not a weight loss alternative. You still have to do the hard yards. You still have to diet. You still have to exercise.
I've just got two more questions and then we'll finish up. So the other one was with basal insulin only.
So as of April 1, you'll be able to do that, yes? And it will work very nicely because it works independent of the insulin. It works on the kidney, not on the pancreas or anywhere else or insulin receptors. It shall work very nicely in terms of deferring the requirements for insulin.
And would it be with insulin for both type 1 and type 2 or just type 2?
Type 2 only. It won't be used in type 1, although there are trials showing that it does work. There are real risks of ketoacidosis associated with it, and it's not somewhere you should go with someone with type 1 diabetes. There'll be other alternatives in the future, but this is not a safe alternative for type 1, certainly at this stage and probably never.
Okay, well that's pretty much all we've got time for tonight. So if there's anything that Gary or Nicole would like to end with or make final comment on, you can do that. Otherwise, we'll wrap up.
Yeah, just to say that the second-line agents are, I guess, all finding their place, and probably the natural comparator for SGLT2 inhibitors are DPP-4 inhibitors. And we do have a couple of head-to-head trials between SGLT2s and DPP-4s, and SGLT2s do seem to be a little more efficacious. So if you were looking for efficacy, among the second-line agents, and you wanted to stay away from agents that cause hypoglycemia, this might help stratify your choices.
And I think one of the other questions that had come up earlier today was the cost equivalence, and I think obviously salts are cheaper, but DPP-4s and SGLT-2s are certainly on the same cost parameter for patients, so that's certainly not a deciding reason for prescribing either.
And hypos and weight gain are costly for a number of reasons as well. For those of you still there, I just also remind you that our next session will be on DPP-4s specifically, and we'll have an interesting case discussion around their utility in all of these contexts in the next ADEA seminar.
Excellent. So thank you very much to Merlin, Gary and Nicole for joining us this evening. There will be a evaluation questionnaire being sent out after the session, and like I said in the beginning, the session was also recorded. So if you'd like to go back and view it, you can do that probably within the next 24 hours and onwards. The next webinars that we have on this series are open for registration, so you can go to the ADEA website and register for those as well. So thank you for attending, and we will see you again next time. Thank you.
Thank
Bye.
you. Bye.